Welcome to the Shockwave Therapy Podcast. My name is James Woolidge, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concepts of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you. Welcome to episode 2. Today we are joined by Cliff Eaton, a physiotherapist with a master's degree in sports injury management. He's also clinical specialist at DJO Global, one of the most experienced teachers of shockwave, certainly that I know of in this country and probably through Europe. He was the person that got me started on this journey. There's not many people that know more about the details of shockwave in terms of the mechanisms, the actions and so forth. So we're really, really privileged to have him talk with us today. So, welcome Cliff. Thanks for joining us today. This is the second podcast that we're doing on shockwave therapy, and I was really keen to have you come on because I know that when you initially taught me nearly 5 years ago, the way that you get the information across, which can be somewhat complex, is really easy to understand. So a lot of people get bamboozled by what's out there at the moment with the shockwave because it's become a new fashion almost that everyone wants to jump on board with. But so the main aim today for me would be to clear up some of the rumours and to just be a bit more concise about the evidence base and what conditions we're going to be using it for. So can you just kick off? Can you just give us a brief history of shockwave in MSK?
Yeah. Well, thank you much for the introduction. Yeah, I'm a simple soul, so I need to have a clear understanding in my own head in order that I can be able to teach to other people so they can understand. But shockwave. The destructive force of shockwaves, we really came to the fore during the two world wars, where service people were found dead with no apparent external injuries, and they found on autopsy that their lungs had been badly damaged by compression waves from the bombs that had been dropped and explosions near them. And then in Germany, during the 1960s, they started to hypothesize about how they could harness this energy for therapeutic use, and started animal trials in a hospital in Munich during the 1970s, looking at how they could focus this shockwave energy to disintegrate kidney stones. And in 1980, we had our first successful human treatment using focus shockwave to break down a kidney stone, and this is now known as lithotripsy. And now during lithotripsy, they also considered lower urinary tract stones, but concerned about potential damage to bone and soft tissue, they lowered the energy. And as an incidental finding, they actually found that they were getting increased bone density and promoted tissue healing in the area. So that sort of led to lower energy focus shockwave being used to treat musculoskeletal conditions. And you'll find the first sort of papers in 1991 using focus shockwave to treat skin wounds and pig skin. And around about the same sort of time, we started to find papers for using focus shockwave for non-union fractures. Now, the interesting thing with non-union fractures is it's now, focus shockwave is now commonly used for that. In fact, in Austria, it's now the first choice of modality because they're getting better outcomes than they are with surgery, and it's a lot cheaper.
Yeah. I mean, funnily enough, I've just treated a motocross rider with a non-union tibia. And that was with consent from his surgeon, who said, look, if we can do anything else apart from going in again and operating, then great. He's currently, this is his first week back on the bike. Actually, I'm waiting for his CAT scans to come back to see the actual change, but it was looking very promising with the focus shockwave.
Yeah, so I treated a downhill skier with a non-union tibia fracture, and after 3 or 4 weeks, we were told to stop because it was actually producing too much callus.
Wow.
It's quite interesting, yeah. But then obviously, then over the coming years, more and more applications for focused shockwave were trialled over a variety of musculoskeletal conditions, cardiac and urological pathologies. What happens with focused shockwave is we produce a shockwave energy that accumulates deep into the tissue to a small focal point. And around about the turn of the century, musculoskeletal therapists asked whether it would be possible to produce a shockwave that could be used more superficially and treat over a larger area. And again, in Germany, they devised a device that produces energy at the skin and radiates out into the tissue. And so this was marketed as radial shockwave. So in the marketplace, then we had these two shockwaves: focused shockwave and radial shockwave.
This is where it starts to confuse people, doesn't it? Which is you're going to add that excellent ability to get complex things across, Cliff. So that was going to jump on to a third or fourth questions, but while we're on the subject, why don't we just tackle it now? So what do we think is for the average user out there in terms of the two types? Can you just go through that a little bit more about what we should be looking at and what conditions and why there is a difference between the two?
Okay, yeah. So this is an interesting debate. The purist shockwave therapists will always tell you to use focused shockwaves. That is produces a true shockwave, and the majority of evidence supports it for treating chronic tendinopathies. And it's been around a lot longer than radial. I'm going to say radial pressure wave, and I'll explain to you a little bit later. But I just want to get that terminology across to everybody. But there's certainly a larger quantity of evidence for focused shockwave compared to radial pressure wave. Kathy Speed, a consultant rheumatologist from Adam Brooks Hospital in the UK, and she also works in London. She's written two systemic reviews, one in 2004 and one she updated in 2014, and she stated about the quality of evidence for focused shockwave being better than for radial pressure wave, pointing out the fact that she could only find one class 1 RCT to support the effectiveness of radial pressure wave for plantar fasciitis. Now, that said, her inclusion criteria were very, very strict, and in her search engine, she didn't use the term of radial pressure wave or extracorporeal activation therapy or acoustic wave therapy. These are the terms which I'll explain later. So that then put a heavy bias on her search towards focused shockwave literature. So Okay, but the biological effects of extracorporeal shockwave in tendinopathies is to artificially produce mechanicotransduction. Now, mechanicotransduction is the mechanism by which cells sense mechanical signals and adopt their biochemical activity, which influences cell migration, proliferation, differentiation, and apoptosis.
Which is, I mean, it's interesting that you describe it like that, because you're one of the few that do, and I think that's actually really helpful, because as you know, I do a bit of teaching myself, and I struck upon this from what you'd sent me some details on, and it seems to strike a much easier chord with people in the audience when you describe it like that, particularly with physios back in the day that we used to using lots of deep friction and so forth, which actually even I was taught, which is, you know, whatever we do as manual therapists, we are inputting mechanical energy into the tissue, and it's the body's response to that creates the healing, or whatever else we want to call it. And I think it's the same when I was explaining it last weekend, that mechanotransduction is no different from the force travelling up the leg, which creates new trabeculae to form. So it forces osteoblasts to basically produce in a particular line of force subject to the piezoelectric forces, subject to weight bearing, which I think actually is really useful. So it's become a little bit mystical as to what Shockwave does, but if we really pare it down to that gives us a really nice grasp of what we're trying to achieve with it.
Yeah, and for those clinicians who integrate exercise therapy into their patient management, mechanical transduction is a normal function of a tendon, especially in the Achilles. And when they're doing their exercises, they're putting load through a tendon, and that mechanical load is picked up actually by little protein messengers called integrins, which are in the cell membrane, and they communicate the pressure, the tension and shear forces which occur in the extracellular matrix, and they convey that information to the nucleus of the cell, and the cell adapts its behaviour. So we adapt naturally to mechanical loads. And what we're doing with Shockwave is producing an artificial mechanical load through the tendon.
Yeah, I think that's a great point, because the other thing that if you can just touch on, so we go back to this. Why don't we tackle the terminologies if we can before we move on to some of the other ways in which Shockwave works? Go through can you just go through the radial pressure wave as opposed to a Shockwave again, and why that's now. Because I've read in the literature is getting there now. It's catching up with this fact that we should be differentiating between the two types. So can you just say why that is?
Yeah. So the International Nomenclature Society are trying to encourage authors now to write about focused shockwave therapy and radial pressure wave. So there are two different methods to provide extracorporeal shockwave therapy. So extracorporeal simply means outside of the body. And I don't know of one clinician, including you or I, that have ever used it internally or intend to. So, but there we are. So then you have focused shockwave therapy, or FSWT, comes from focused shockwave, and that produces the true shockwaves. Whereas radial shockwave, if you were to look at it's actually not a true shockwave. It doesn't produce high pressure over a short period of time. It doesn't have a negative phase, which is referred to as a tensile phase, where we get cavitation. So, strictly speaking, if a physicist was to compare the two impulses, he would say, well, you cannot call that radial shockwave because it's not a shockwave. Hence why we started to use the terminology of radial pressure wave. In America, because I've got to be careful.
You do.
They use the terminology acoustic wave therapy, but which again, describes well what the therapy is doing. So, and then you've also got, just to confuse things a little bit further, linear focused shockwave. So instead of focusing the energy to a point, they're getting true shockwaves, but they're putting it in a linear format, so that they can have a true shockwave spread over a larger area. The thing with this is it doesn't penetrate very deep, so it's very good for treating superficial dermatological conditions and superficial trigger points. They also use it in erectile dysfunction.
Yes. Okay. Yeah, I've heard of that. I think that. So what we're really saying is a few terms which are all not helpful for the users out there, but what we're really 95% of the marketplace across the world is radial pressure wave in effect, isn't it? Otherwise known as radial shockwave.
Yes.
And then the few of us have gone the extra mile and bought focused, but most of that is due to the fact that we've been at it for 4 or 5 years and decided that the types of conditions we might want to treat are a little broader with focus, because you need a higher energy for treating those conditions.
Yeah.
So should we move on to the the other thing I wanted to tackle was that, which I tackled with Paul Hober a little bit actually, but he a lot of people say when they get a machine like ultrasound back 25 years ago if you didn't really know what was going on, or if you didn't know what to do, you're going to basically plug it in and wipe it over the saw bit and hope for the best. And I'm really concerned that Shockwaves are becoming a bit like that, which is everything that saw stick Shockwave on it. And I think that belittles it a little bit and undermines the evidence base that is truly there. So can you just talk us through, if you had to pick, your best conditions that you wanted to use this on, what would those conditions be, Cliff?
Yeah. Again, I'll start with true evidence-based practice, which was supported in the literature. But I'm also a big advocate of anecdotal evidence, what we see with our eyes, and I'm sure many therapists are out there that treat things that perhaps not necessarily supported by clinical evidence, but know they work. Let's start with an evidence base, and there's two international scientific advisory bodies on this. There's the International Society for Medical Shockwave Therapy, that's the ISMST, and Digest, which is for German-speaking countries. And based on the most contemporaneous studies, they advise us that we can, what we can and cannot use extracorporeal shockwave for. There's good quality randomized control studies, as well as strong empirical evidence to support the use of extracorporeal shockwave for chronic tendinopathies, including all your sort of lower limb tendinopathies, your upper limb tendinopathies, including rotator cuff with calcific deposits. Treatments for dermatological conditions, wound healing, psoriasis, scar tissue, and bony pathologies are only applicable with focus shockwave.
Yeah.
Now, you can use both focus shockwave and radial pressure wave to address myofascial conditions such as trigger points. Your deep-seated myofascial trigger points, which are not perhaps easily palpable, you can diagnose with focused shockwave, and then be able to treat them. There's also good evidence for radial pressure wave in increasing extensibility of time.
Sorry, Cliff. Can I just stop you there? Because one thing that we've just missed upon it occurred to me is the difference between the focused and the radial. Because you mentioned about almost using it as a diagnostic tool, which is really important, because actually I use that because it's about the depth of penetration. So can you just cover the difference between the two as well, about depth of penetration as well as just energy levels?
Yes, yeah. So focus shockwave, as I mentioned earlier, focuses the energy, and the focal point will be around 5 or 6 centimeters of depth. Now, we'll perhaps talk about this later, about the different forms of generating a focus shockwave, but they have different focal areas. That's the treatment area around that focal point. So certain focus shockwave machines, you can get a therapeutic depth of penetration down to about 12 centimeters, so very deep. Whereas radial pressure wave, the energy, the maximum energy is at the skin, and then it attenuates as it travels down into the tissue. Now,
what kind of depths are noted for those? I know the answer partly, but for people that are listening, you can change applicators and you can slightly modify. But what are the average depths we're looking at with radial?
Yeah, so this is an important consideration for people, and we'll touch on this later, I'm sure. But the quality of your transmitter determines how much energy goes into the tissue, and the amount of energy goes into tissue determines the depth of penetration. Now, with radial pressure wave, you're using a projectile to hit a transmitter. And when the projectile hits the transmitter, it produces a high frequency ultrasonic waveform. And this produces shock waves and cavitation, but at very, very superficial level. So with a standard transmitter, you'll get a depth of penetration of about 5 millimeters. But the deeper effects you you find with radial pressure waves come from low frequency sonic waves. Now these are pressure waves, and they've been measured as low as 7.5 centimeters into the tissue, so quite deep.
Okay, fine. And I think when you do your training as well as I do mine, we sort of teach that concept, because most people will end up buying radial devices, and the heads that you can buy will determine the penetration depth. And also you can, with the machines, ultimately you can play with two things, can't you? The bar pressure and the frequency. And the less of the frequency is the more depth, if you like, as a possibility, along with combining it with increasing bar.
Yes, this is what the salespeople will come and talk about. They'll talk about the bar pressure, which is the pressure within the barrel of a radial pressure wave machine, and they'll talk about the frequency. The frequency is the number of times that a valve will open and close to let the compressed air into the barrel. Now, you're not going to find anything in the literature that suggests that frequency makes any difference. Yet, anecdotally, clinicians find that the higher frequency you use, the more tolerable patients find the application of shockwave. Whereas the amount of the energy coming out of the transmitter is the most important consideration. Because you can get two manufacturers with the same amount of bar pressure and the same frequency. But if their transmitters are made of different material or different shape, different design, the amount of energy coming out of the transmitter will be different. So it's a bit like me, taking a sort of a toffee hammer, if you like, and striking a piece of steel, and using the same amount of pressure, striking a piece of foam. So I'm putting the same amount of contact into both materials, but the amount of energy that's going to come out of the steel is going to be a lot more than coming out of the foam.
Okay, so that's an interesting point, isn't it? So do you not, when you're doing your courses, do you not suggest a certain amount of frequency? So do you not think that there is a certain change in frequency that would give a certain change in depth of penetration?
So no, the depth of penetration isn't necessarily changing the depth of penetration, but it's changing the pressure. So the way I liken this is to consider low frequency as bass music in sound. Mm-hmm. So if you were to go to your sort of raves and your music concerts, I want to say discotheque, but I'm sure most of your listeners...
I'm with you on discotheque. I'm with you on that.
Wouldn't remember discotheques like you and I. But if the DJ was to keep the volume the same but turn up the bass music, the bass element of the music, which is low frequency, then you actually feel this sort of vibrating through your body.
Sure.
Okay, so it's that. I don't want to use the word penetration. It's just more force. If you like.
Okay. All right. Fine. All right. So the other questions we always get asked when we run the courses that we run, certainly I do, is that I do work. I've stated this on the one before. I do work for Venn. I do my teaching on behalf of them and STORZ. And people are always very keen, to take you off to the side in a coffee break and say, well, I've heard about this company and I've heard about that company and so forth, and there's no point skirting around it as long as we both say, look, you work for DJO, which uses STORZ equipment, but there are other companies out there. What as a general rule of thumb, I know what I say, but what do you say to people out there that are thinking about buying into this technology?
Okay, so this is Yeah, like you, I get asked this question regularly. Now, I consider myself as an educator. I do work for a commercial company, but that's an excuse that I can spread best practice around the world. And my one rule is that I don't want to know the prices of their machines. I openly say to people at the beginning of a course, I'm not a salesperson. I'm not here. I'm not on commission. I'm not on bonus. I'm going to simply tell you the facts. Now, obviously, working for a commercial company, they've got they've got pictures of the Chattanooga machines up, so Chattanooga get brand awareness out of it. Okay.
Yeah.
I don't think it's fair to recommend. So I never think it's fair to recommend one manufacturer over another, especially as clinicians have their own criteria when purchasing. But the thing that I say to them, as I alluded to earlier, okay, the most important consideration when buying a radial pressure wave machine is what is the energy, and that's called energy flux density, or EFD. That's what they're going to read about in the literature. What is the energy flux density emitted from your transmitter? And if a salesman can't answer that question, then I advise them to steer clear from that, because that is what's giving the therapeutic value to the patient.
I think there are you see that occasionally in the literature about that, but I think some companies are slightly more honest about what their machine delivers, and some machines, well, other machines are not, or manufacturers aren't so much, are they?
No, and I mean, you know, there's manufacturers jumping on the genuine interest in Shockwave, and quite rightly, because it is a well evidenced based modality. So you know, there are cheaper and cheaper machines being produced. Electromagnetic. So I should just say that with radial pressure wave, you produce the pressure within the barrel from a compressor, which can be an oil compressor or an air compressor. And air compressors are always best to buy because they don't require sort of servicing in a way that oil compressors do. But there are Chinese manufacturers now promoting electromagnetic form of producing a radial pressure wave. Now, currently, I'm not aware of one piece of clinical evidence to support the use of electromagnetic to produce a radial pressure wave. And I've actually spoken to the Chinese manufacturers when I've been lecturing over there, and not one of them can tell me the EFD of their transmitters. So I tend to steer people away from
but
that.
Cliff, they're a third of the price, and that's quite compelling.
Well,
that's
the thing. I mean, look. If you're buying a Shockwave because you want to put on your website or whatever, your marketing material, that your practice has Shockwave, that's what you're buying, as far as I'm concerned.
Yeah.
Okay.
Yeah.
I'm more interested in clinical outcomes and supported by evidence-based practice. And if you look at the evidence, then the evidence is using radial pressure wave or focus shock wave, but the radial pressure wave being produced by an air compressor. So
sure, okay, all right.
Okay.
So
just let me say, because there's another. I think this is quite an important consideration for people as well from a safety aspect. Is that low frequency sonic wave that I talked about, produced by the transmitter, not only travels into your patient's tissue, but also back into the handpiece. Okay, so if you're holding this handpiece, that low frequency can come into your fingers. So it's important to check that the handpiece passes the EU Medical Device Directive, which is 93/42/EEC, which has been observed to prevent white finger. And that's a painful condition which affects your hands. So some manufacturers have to put in their handpiece not to use their handpiece for more than 20 minutes at a time, and a maximum of 2 hours per day. And handpieces which are made solely of steel are particularly susceptible to this. And obviously, they're cheaper handpieces, so you can see why sort of people would do that. But,
yeah, sure. Okay.
They're their main considerations to look at when you're looking at radial pressure wave. The choice of focus shock wave is slightly less complicated. There's three ways of generating a focus shock wave. There's something called electrohydraulic or a spark discharge. It's a bit like the spark plug in your car, and you can imagine sort of putting that against your skin. It'd be quite uncomfortable. So that's likely to require a local anaesthetic. And if you've heard patients sort of say, I've heard or read that Shockwave's, very uncomfortable, then that's more to, they've probably had or reading about electrohydraulic. And that form of generation is popular in lithotripsy. The two main types of generation that we use in clinical practice is you've got the choice between piezoelectric and electromagnetic. Now, piezoelectric uses those piezo crystals that we use in therapeutic ultrasound heads, which produce ultrasound. But they use hundreds of these, and some manufacturers have a double layer, so they can have thousands of these crystals in a dome or a cone, if you like, and they accumulate the energy deep within the tissue. And because the energy is spread over a larger area when it's transmitted through the skin, it's much more comfortable. That's on the plus side. On the perhaps the negative side, it only produces a very, very small focal point. The focal point can be anywhere between 2 to 5 millimeters, so it's quite small. So you have to be very precise in your placement. The precision of your treatment is important. And a fellow colleague lectures from Norway talks about his two best friends. One being his focus shockwave, the second being his ultrasound imaging machine, and he uses the two in conjunction to make sure that he gets the best placement. Because you need to be sort of quite precise with your placement. So that sort of adds an additional cost, but also an area of expertise where you're able to read the ultrasound imaging. Again, on a down note, but I'll address that. But is that piezo crystals do denature over time. So over the life of the handpiece, the power output does gradually sort of diminish. But on a positive note, piezo crystals are cheap to produce, so the handpieces tend to be cheaper. The two main players in the focus shockwave market, they choose to use electromagnetic technology. Now, this is a bit like your loudspeakers or your music speakers you use at home, where you'll put an electrical current through a diaphragm which vibrates, creates sound. Those sound waves are reflected into the tissue by something called a paraboloid reflector, and again it's spread over a larger area as it enters the skin, so it's comfortable, and then accumulates to a focal point deep within the tissue. The advantage is that it has a much bigger focal area than you get with piezoelectric, so you don't need to be quite so precise in your placement.
And on that note, I know that I've got one of those. Do you use that as well as radio in your practice, Cliff? If you're still doing some,
so like you said earlier, James, is that a lot of therapists, because it's a capital expenditure for the practice, but a lot of people put their toe in the water, if you like, with radial pressure wave. And once they see the results, then they sort of will invest then into focus shockwave. But it doesn't mean to say that they set aside their radial pressure wave, because there's a big move now, and this was advocated by people like Marcus Gleitz in his paper of 2012 and 2015, that the combination of the two work really well together.
Yeah.
Radial pressure wave is very good for increasing extensibility of tight calf muscles, for treating superficial myofascial trigger points, where your focused shockwave is good for getting the deeper myofascial trigger points, but the cystic changes within a chronic tendinopathy.
Right. Okay. People have also, they say to me, is it going to be another fashion? Is it going to be like ultrasound was, or some of the other things that you can plug into the wall? I mean, my view on this when I got you to come up with me 5 years ago was that I could just see the exponential increase in the research and evidence base for this. So over the last 5 years with its increase, I mean, do you see it continuing to grow, and what's the evidence suggesting that we do with this now?
Okay, that's a great question, actually. So let me start with a quote from Dreiselker in 2015, German orthopedic surgeon. He said, "No other conservative orthopedic treatment has had so many independently validated studies, primarily from the university sector, the Shockwave. We seriously have researched Shockwave to death. We know it works. Where we have the issues, and what authors are all agreed on, is that we don't have any heterogeneous studies. So we've got different ways of generating focused shockwave. We've got different energy values coming out of transmitters in radial pressure wave. We've got authors using different protocols to treat the same thing. So in order that we can start having better meta-analysis in the literature, we need to come up with an optimal protocol. Now, that optimal protocol was suggested by Schmitz et al. In 2015, having sort of reviewed 326 different articles across a range of pathologies. But the first published studies pertaining to MSK, as I said earlier, was to do in the 1990s, and as you said, exponentially they've increased over the past 5 or even 10 years. So we now have a lot more systemic reviews and meta-analysis published. But as I say, it's very, very difficult to get this meta-analysis due to the different types of generation of the different extracorporeal shockwave. But that paper I mentioned by Schmitz et al. Has shown that it's proven as an effective, safe and non-invasive treatment option for treating tendinopathies. And if we look at the evidence for things like urological conditions such as Peyronie's disease, chronic pelvic pain syndrome, erectile dysfunction, all been shown to benefit from focused shockwave interventions. And I'm just talk about that erectile dysfunction, because I always get sort of asked about this, and therapists wanting to use it as a treatment. The evidence supports the use of extracorporeal shockwave for erectile dysfunction with vascular disorders. So I always insist that you get a urologist involved, to ensure that we get correct diagnosis and prescription. Okay?
Yeah.
There's been a recent study by Sizzler et al. 2018. It was published, I think, March. That demonstrated the positive results of focused shockwave to expedite acute muscle trauma. This was done in animal trials, and the research is still in its infancy, but it's worth keeping an eye on. I think the big debate, though, James, is between exercise and shockwave.
Yeah.
I'm just on my way to sort of Australia, and we have a lot of keen researchers over there on tendinopathies advocating exercise.
My take on that, Cliff, is that I find it a bit confusing in a way, and I think that sometimes research can do this, where I'm not suggesting egos get in way, but it does seem so adversarial that people then pitch certain interventions against others, and you get this huge exercise, graded loading program, that's all we need to do. Shockwave isn't as good as it, so therefore we're not going to consider Shockwave. Or vice versa, get the lazy therapist that says, Shockwave is the answer, there's no point doing any graded loading programs, blah. But why on earth can't clinicians be trusted to choose what's best for the patient between the two, and what's likely that is this patient going to be adherent to the program? Great, let's really go for graded loading program, and if it stalls, if it doesn't really work out, let's add some Shockwave in. And that's the sort of general clinical decision making that all experienced and good therapists should be doing, really.
Yes, I mean, I don't think it's sort of ego so much, but researchers getting a bit blinkered in their own sort of speciality, and perhaps when they're doing their reading around the subject, perhaps just concentrate on exercise, for example, or Shockwave, and not looking at the combination. I'll use one of the most cited pieces of literature, Cook and Purdom, 2009, on the continuum theory on tendinopathies.
Yeah.
And that's a great model. And they suggest that the exercise interventions are most effective in the reactive stage of tendinopathy and become less effective the more we move towards tendon disrepair and time we get to a degenerative tendon, which, face it, is where we generally see most of our patients. Suggest that exercise prescription won't work. In a follow-up paper, 2016, they went on then to add in reactive on dysfunctional, degenerative tendons, and then said we should start shifting sort of sideways then, and just looking at pain modalities. But so, I mean, there is good, strong quality evidence to support the use of a graduated loading strategy for chronic tendinopathy. And Mani Babu et al. In 2015 actually sort of said that the quality and quantity of evidence for Shockwave matches that for a graduated loading strategy in the lower limb. So if you bought into one, why can't you buy into the other?
Absolutely right.
And my argument is it's not a choice between Shockwave and exercise prescription.
Yeah.
It's a combination of the two. With Shockwave, you're influencing things at a cellular level. You're getting the cell to produce more building material, if you like. That building material is put onto the building site, the injury site, and then you're going to influence those new collagen fibers with your exercise prescription.
Yeah, that's a great way of summarising that, actually, Cliff.
Yeah. I use a sort of building site analogy that you get your building materials on site first, and then you get your builders in to use those materials to build whatever type of property it is that you're trying to build.
Yeah, sure.
And so that's supported in the literature when you look at things like Achilles tendinopathies and patella tendinopathies. So,
Oh, okay, fine. And if we draw this to a close, and you had to pick your three best patients that were candidates for using Shockwave in terms of conditions, age, other aspects of activity. If you had your three best patients that you wanted to treat with, what would those three people have, and what would you say about that?
The majority of the literature is on plantar fasciitis and Achilles tendinopathies. So those the two go-to things. But and for me then moving on to rotator cuff.
Oh really? Oh, that's interesting. I found.
Also, I'm only allowed 3. You said, well, I get good results with lateral epicondylitis as well. But if
where are you at? Because I started looking at graded trochanteric pain syndrome about a year ago, and I have to say that before I even got my focus, using the different applicator for a deeper or more energy into the tissue as such with my STORZ, you can get some amazing results with those, because for me anyway, the sort of population group you get with that condition, far more many women than men, the middle ages, then I know that there is, I always try and combine it with graded loading programs and so forth, because we've got an excellent physio, you remember here, Tom, but there's some demographic groups are just not very compliant with graded loading programs. No. And actually, if you can get someone sleeping on their side with GTPS over 2 or 3 treatments and they sleep better, my goodness, the progress they make. I've found that personally. So that's become my number 3 over PF.
I'm perhaps seeing a different type of clientele, but what I need to sort of say on that is that Benjamin et al.'s work, they talk about the enthesis organ, and this is important over the greater trochanter, but also over insertional Achilles tendinopathies. That an enthesis organ is the tendon, the bone, and the bursa, and you need a differential diagnosis. Because if we go back to greater trochanteric pain syndrome, in the NICE guidelines, they talk about trochanteric bursitis. You're not treating a trochanteric bursitis.
No. But I think the world has moved on a bit from that.
You're treating an insertional tendinopathy. Now, if you've got a true bursitis without any sort of tendon bone involvement, then actually Shockwave can make that worse.
Right. Okay.
Because Shockwave is a pro-inflammatory, and
sure.
Obviously you've got an inflamed bursa. So.
But when you look on, if you're bored one day, which I often am, and you Google image trochanteric bursitis, or in the same way that olecranon bursitis comes in and smacks you in the face, you do see those, and you just think that's unmistakably a big bursa that's hanging off the trochanter. They don't sort of sneak up on you, but anyway, I think most of the ones we see in practice are just tendinopathies. But I think what we might do is get you back at some other time. So I think that I've also known you've done some work with Professor Tim Watson on this, haven't you? And helped him write some chapters in his new book that he's coming out with. Is that right?
Yeah, it's actually with the publisher Elsevier now. Yeah.
Oh, okay. Is that a general electrotherapy update as such?
Yeah, so that's his 13th edition of his electrotherapy update book. But this time, because electrotherapy is not strictly true. For example, Shockwave is a mechanicotherapy. So the title will be something like Electrophysical Agents, the evidence-based practice.
Oh, okay, fine, all right. Okay, well, look, I'll go out and buy the book for sure, just for helping me out on the podcast today. Cliff, this has been, I've learnt a great deal myself today, actually, especially on how you explain things using metaphors. I think that's useful for people out there, and hopefully they've learned something about the different types of energies and different types of machines and exactly what we're trying to achieve with this. So thanks very much, and we might get you back into another podcast at some point later on in time.
Yeah, I look forward to that greatly, James. It's always a pleasure to chat to you.
Thanks a lot, Cliff. Cheers.